Welcome to Health Disparities in Breast Cancer, a virtual town hall sponsored by Mayo Clinic in partnership with the Coalition of Blacks Against Breast Cancer, also known as CBBC. I am Denise Johnson, today's moderator. I am a 4-year breast cancer survivor and the executive director of the CBBC. CBBC has supported Black breast cancer survivors in the Phoenix area for 11 years, and Mayo Clinic is one of its founding partners. It is an extreme honor for me to introduce this panel today. Personally, I am grateful for their support and contributions to my cancer journey. We have first Dr. Michelle Halyard. Dr. Halyard was appointed as the Susan Hansen Poole Vice Dean of the Mayo Clinic Alex School of Medicine in April 2013. In addition, she is the inaugural dean of the Arizona campus of the Mayo Clinic Alex School of Medicine, which opened in July 2017. Dr. Halyard is a professor of radiation oncology at the Mayo Clinic College of Medicine and Sciences and is board certified in therapeutic radiology. Her area of expertise is in the treatment of breast cancer. And if I may add, Dr. Halyard is co-founder, along with Mr. Marion Kelly, of the Coalition of Blacks Against Breast Cancer. Welcome, Dr. Halyard. Next, we have Dr. Donald Northfeld. Dr. Northfeld is Associate Medical Director of the Breast Clinic at Mayo Clinic, Arizona, where he is responsible for the care of many patients with breast cancer. He also sees a substantial number of other cancer types. He is the site director for the Center of Health, Equity, and Community Engagement Research in Arizona. This program highlights underserved populations and their need for greater access to cancer care and representation in medicine. His work involves complex situations and treatment decisions with cancer patients at a high stress time for patients. Dr. Northfeld is a long-standing CBBC supporter and speaker since its beginning. Welcome, Dr. Northfeld. I'm honored also to introduce two very special CBBC members. I appreciate their willingness to share their survivor journey with you today. First, we have Sandra Tinsley. Sandra, we know her as Sandy, was 65 years old when she had her first brush with cancer, breast cancer in 2008. She was diagnosed with ductal carcinoma, stage 0 in her left breast. In 2020, right after beginning the pandemic, Sandy was diagnosed with invasive breast cancer, again in the left breast. However, it was found early at stage 1. She is almost back to normal after completing her treatments and very thankful for her faith, friends, family, and regular mammograms. Welcome, Sandy.
I was 52 years old with the first and 64 with the second one.
Thank you for. I wouldn't believe that you were 65 now. Thank you for the corrections there. And next we have Pamela McCall, known to us as Pam. Pam worked as a mammographer for 19 years before being diagnosed with breast cancer in 2003. It has been 18 years since her diagnosis, for which she is humbled, thankful, and very grateful to God. She was diagnosed and treated here at Mayo Clinic, where she presently works in radiology as a systems analyst. Welcome, Pam. Before we begin, I invite our audience to use chat for comments and also the Q&A to post questions. We will be monitoring both of these and we'll allow time at the end of our presentations to answer your questions. So let's get started with Dr. Halyard.
Hi, everyone. Thanks for being here at our presentation for Breast Cancer Awareness Month. We're glad you took the time to listen to the information that we're presenting to you and hope that you'll have lots of questions for you. In the few minutes that I'm going to speak, I wanted to provide some information that I hope will be helpful to you, particularly for those who have not been diagnosed with breast cancer, and then talk a little bit about CBBC for those who have been. So when people ask me about breast cancer and what can they do, I say, first of all, breast cancer awareness is not a slogan. It is something that you should live by. So I always talk with individuals about the fact that particularly women, but also men, because they can get breast cancer too, to know what is normal for your body. So it's really important that you examine your breasts monthly. That's our recommendation, even though the recommendation for a specific date and particularly monthly has kind of gone out of vogue. I say at a minimum, do it monthly, more frequently if you can. I want you to think about looking at your breast in the mirror and saying, is this normal? So sometimes breast cancer can present with a difference or a change in your breast. Do you have one breast that's gotten larger than the other? Is there a difference in the color? Is it redder or a purplish area, or purple changes in the breast? Has there been a nipple inversion, the nipple pulling in? Has there been a thickening or a dimpling of the skin where it looks like an orange peel? If these things haven't been present previously, and in most people they aren't, you should seek medical attention. But it's not enough to just look at your breast, you need to examine them. And so what I would recommend is that you examine both lying down when your breast is dry and feel every aspect of your breast, including the tail of the breast, which goes up into the armpit area. Most people think that breast cancer only presents as a lump or a hard knot, but that's not true. It can present in many different ways. It can present, yes, as a mass, but it can present as a thickening, or it can present as a painful area. You need to know what is normal for you. You should also consider examining your breast in the shower with using soapy fingers, which help you to slide over the skin of the breast pretty easily and feel things perhaps sometimes that you can't feel when the breast is dry. So if you notice any changes, please seek medical attention. The vast majority of things that you're going to feel in your breast are benigns, and particularly for younger women who their breasts may change with their period or at different times of the month. But please seek out medical attention. The next thing that is important to know is how frequently you should get a mammogram. And I'm the first to admit that sometimes the information out there is confusing because there are different guidelines. The American Cancer Society and Mayo Clinic recommend that you start your screening mammogram, meaning that a mammogram when there's nothing particularly wrong, but you're just checking at age 40 and do it annually. There's an organization called the U.S. Preventative Task Force that puts out some different recommendations and says that between age 40 and 49, it's optional to screen, and you should talk with your primary care or other healthcare provider about when to start screening. But they recommend to start screening at age 50 and to do it every other year until age 74, and then to stop screening at 75. The take-home message that I give to you is to really talk to your healthcare provider about what is best for you. Don't be afraid of mammograms. Yes, there might be a little bit of discomfort as they're doing the mammogram, but it is well worth it to save your life. Early detection is the key. And lastly, if you are diagnosed with breast cancer, we invite you to join the Coalition of Blacks Against Breast Cancer. As Denise said, we've been going for 11 years, and we have two main goals or missions of our organization. One is to provide support to Black breast cancer survivors, and we define survivor as anybody from the date of diagnosis forward. And we want to provide a nice supportive environment for them so that they feel comfortable, so that they can get their questions answered, and that they feel the support that they're needed. It's not only for survivors, it's for co-survivors or family members or loved ones as well. So we welcome you. And we meet virtually 3 to 5 p.m. the third Sunday of every month. Our website is cbbcaz.org to get more information. The other thing that we do is provide education outreach to the community, and our survivors are a key part of that as they tell their story. So if you have need within your community, members or clubs or churches, to get more information about breast cancer, please call on CBBC. We're happy to come out and talk with any group that wants to have us. So thanks for letting me give this information. Hope it was helpful and look forward to answering the questions.
Thank you, Dr. Hilliard. I know the question of when and how often to get mammography screening was very confusing for me prior to getting diagnosed. So this is very important information, and thank you so very much. And now, Dr. Northfeld.
Thank you very much, Denise. I'm so grateful to have the opportunity to speak with folks on behalf of the Coalition of Blacks Against Breast Cancer. I've had the privilege of having an affiliation with the CBBC for 11 years, and I get inspiration every day from members of the CBC for the good work they do and for their heroism in surviving breast cancer. So I'm very grateful to be here. I'm going to speak briefly about what's happening today in breast cancer care. For those of you who've had breast cancer and been on that journey, some of what I say will sound very familiar, I hope. The first thing I want to say is that we're really doing much better these days against breast cancer than we were even 30 years ago. I started taking care of women with breast cancer about 30 years ago. And the advances that have occurred improving our care for women with breast cancer have really been astounding for me to observe as these decades have gone by. Just one little set of statistics I want to share with you all is that this comes from the American Cancer Society. In the mid-1970s, women diagnosed with breast cancer had a 75% likelihood of surviving 5 years. In the mid-1980s, that number had risen to 85%. So in just a decade, from 75% to 85% likelihood of surviving 5 years with breast cancer diagnosis. By the mid-2010s, so within the last decade, that number is up over 90%. This is among American women diagnosed with breast cancer. So tremendous advances in survival have occurred just in the last 3 or 4 decades in breast cancer care. How did that happen? How are these successes occurring? Well, it's a whole set of important advances that have been made. So, for example, imaging of the breast is much better today than it was 20 or 30 years ago. The ability of the mammographer to see things on your mammogram or to use additional techniques like ultrasound and MR scan to identify problems in the breast. There have been tremendous advances in the ability of the mammographers to tell us that there's a problem. This means that cancer could be diagnosed at an earlier stage when it's easier to treat and eliminate. Now, if we look at the surgeons and what they do, there's been tremendous advance in the techniques of surgery on the breast to more effectively treat breast cancers surgically. So our surgical colleagues are doing a much better job these days than they were in years past, and that's contributing to the success of women with breast cancer. Look at the radiation oncologists, what Dr. Hilliard does, for example. All new techniques in breast cancer care from the radiation oncology perspective, a completely different scenario in radiation oncology than women experienced 30 years ago or even 20 years ago. Improvements in the ability of the radiation oncologist to effectively treat breast cancer. That has contributed to these advances. Finally, what I do as a medical oncologist is prescribe medications to treat breast cancer. And there have been tremendous advances in breast cancer medical oncology care with new medications and new strategies that have been made available in the last couple of decades to improve our care of women with breast cancer. So we can do things now that we couldn't even dream of doing 30 years ago to improve the outcomes of women with breast cancer. And that is reflected in the statistics that I shared with you a moment ago. I do want to make one particular point, though, for African American women, and that is that there's been a lag a tragic lag in the improvement in breast cancer outcomes for African American women. So I mentioned that in the current era, 90% of women survive 5 years after a breast cancer diagnosis. I should say that if a woman survives 5 years, she's probably home free, so to speak. We don't expect the cancers to come back, except in a few rare circumstances as time passes beyond the 5 years. So when I say 90% survival at 5 years, that's time for high fives and congratulations for everyone, because that makes their future look very bright. That 90% figure, that's overall for women in the United States diagnosed with breast cancer. But in African American women particularly, that number is lower. It's only about 84% or 83%. Why is there that difference? Why are African American women less likely to survive their breast cancer? If you go back to all of the circumstances that I mentioned, the screening, the surgery, the radiation, the medical care, there are deficits in all of those categories in terms of what African American women are able to access for their care. So we know that African American women are less frequently undergoing screening mammography. If that were fixed, it would go a long way toward overcoming this disparity. To have diagnosis of breast cancer made earlier through screening when the tumors are smaller and can be more easily removed, that would be a big advance. We also need to make sure that African American women have access to the downstream care, the better surgery, the better radiation oncology, the better medical oncology care that they deserve in order to overcome this disparity and have just as good an outcome as everybody else in our country. So there are many things that we need to work on, many things that we need to correct in order to overcome this disparity and bring our African American patients to the same level of success that everyone else is achieving in breast cancer care in the United States today. And we are working on that diligently at the Mayo Clinic. We're working on that diligently within the Coalition of Blacks Against Breast Cancer to bring about better hope and better outcomes for African American women with breast cancer.
Thank you so much, Dr. Northfelt. I do have a question as it relates to dense breasts. Many African American women have dense breasts. And can you talk a little bit about how that might impact the mammography screening?
Sure. Breast density is a problem because on a mammogram, dense breast tissue looks white or gray. And cancers also look white or gray on a mammogram. So it's possible for breast density to hide a cancer in the breast. And there are various techniques that we can use to overcome that. We have contrast enhanced mammography, we have MR scanning, we have ultrasound exam that can, at least to some degree, overcome the problem that breast density creates to allow us to see the breast tissue more clearly and find those small cancers when they're easier to cure. So it's important for women to understand about their breast density. It's important for women to seek better answers. If they're told, well, you have dense breasts, have a nice day, that's not satisfactory. Women need to go back and say, if my breast tissue is dense, what else are you doing for me to help make sure that I'm okay? And our medical systems are geared now toward addressing that, but sometimes it requires a patient to bring it up in order to get that attended to.
Thank you so very much. Now I would like to focus a little on our survivors, Sandy and Pam. Um, as a survivor, most of us, at least in our CBBC circle, we talk about how many years, that we're survivors. Can you tell me what that means to you? Why is it important that we share the number of years?
Sandy, you want to take it?
Sure. Well, first diagnosis I got was in 2008, and it was actually considered ductal carcinoma inside 2. It was a pre-cancer. So I did have to, of course, get a lumpectomy, and I treated in Mayo Clinic. I got what they call a mammocyte treatment, which was directed radiation through a balloon filled with saline. So it was a lot less damaging. And this was at the Mayo Clinic with Dr. Michelle Halyard. And it goes back to what Dr. Norfelt was saying, where there's different treatment options available and to know your treatment. But I had always felt like I wasn't really a breast cancer survivor because it was pre-cancer.
Mhm.
And I did actually feel a little guilty sometimes going to my meetings because I didn't feel like a survivor. But 12 years later, I was diagnosed with invasive cancer after 12 years. And yeah, it took a long time for it to come, but it was treated very differently. But I can say I'm a sure enough survivor now, and I look forward to another 12 years of being cancer free because it's nice knowing that that's out of your body. Yeah, it's
12
nice.
years and beyond.
Yeah.
Pam?
So for me, I was diagnosed in 2003. So it's been some years now, 18 years or so. And I'm a classic case of the healthcare professionals not taking care of themselves as well as they should. I worked in mammography as a mammographer. So I had done mammograms for years. And then but I was always too busy for me. Now, mind you, I go to the machine every day and I'm giving mammograms to women every day. And so I was diagnosed a little further along. I was actually a 2B, but I was treated, fortunately for me, here at Mayo Clinic. And I tell you, these people on the line, these are all like family. Like I love everybody on this panel. Dr. Northfelt's my uncle. Dr. Halyard's my aunt. Miss Sandy is my aunt. Miss Denise is my aunt. So once you join this group, you get this automatic family. And so I would be like your cousin, kind of. So, but it's been a wonderful experience. And what I find is that I have these wonderful people who, to whom I get access. And as an African American female, just like Dr. Northfelt was saying, access is very important. So if I have here it goes. If I have Uncle Dr. Northfelt and Aunt Dr. Halyard, I've got access. And so that's kind of how I feel about these people on the call. And of course you, Miss Denise and Miss Sandy. So
Well, thank you so much, Pam. I want to talk a little bit or see if we can get both Dr. Halyard and Dr. Northfell to talk a little bit. We're putting out these numbers, 0 being diagnosed at 0 level, 2B for Pam, and for me, it was 1A. Would you be able to give a little clarity to these numbers for us
Yes, so
and what they represent?
yes, and this is often a question that we have for breast cancer patients because there's two distinct different types of numbers that you're going to hear if you're diagnosed. One is the grade and one is the stage, and sometimes that gets confusing. So grade is something that you'll see on your pathology report, and it talks about how abnormal the cells are compared to normal breast cancer cells. So compared to normal cells. So a grade 1 tends to connote a breast cancer that's the least biologically aggressive, and grade 3 is kind of the most biologically aggressive, at least under the microscope. But then there are other factors called the stage that really play into ultimate outcome. So there's 3 components. There's the T stage, how big your tumor is. There's the N stage, whether your lymph nodes are positive or negative. And then there's M, whether you have evidence of distant spread through the bloodstream or not. We also look at other factors called receptors, little proteins that sit on the surface of the breast cancer cell, estrogen and progesterone receptors that are proteins that really are impacted by the female hormones circulating. around the body. And then HER2, which is another receptor. Black women have something called triple negative breast cancer, which is the most aggressive type of breast cancer and tends to occur in younger ages. We tend to have that in a higher rate. So I just kind of threw that in because people often ask about triple negative. But yes, it is confusing sometimes. But if you are diagnosed with breast cancer, one takeaway message that if you remember nothing else is to keep asking questions until you understand. Make sure that the doctor that you're seeing explains to you what a grade is and what yours is. What stage are you? What import does that have? How is that going to impact your treatment decision? Because too often we see folks that just kind of go along because obviously folks are overwhelmed sometimes when they're diagnosed and they don't get their questions answered, or they're timid to ask questions. So keep persisting and understand the information about your breast cancer. And if you're a family member, be that voice of support and go with them to appointments and ask the questions for them if sometimes if the patient doesn't want to ask the question themselves.
Thank you, Dr. Halyard. Dr. Northfeld, anything to add there?
Yeah, I just want to make a mention about the concept of stage, because I'm not a big fan of it. Stage is a way of describing the extent of the cancer, how big it is, and whether it's in the lymph nodes in your armpit. That was a concept that was developed in the 19th century, literally before 1900, that doctors would, tell you about your cancer based on how big it was in your breast and whether it was in your lymph nodes or not. That's just a snapshot in time. That doesn't tell you how long it took to get that big. It doesn't tell you how big it's going to be in 6 months if we don't do anything about it. And what we really want to know about breast cancer is, how's it moving? How fast is it growing? How threatening is it in that way? But stage can't tell you that. So now we're in the 21st century, and we can probe the genes in the cancer cells. The genes are the chemicals in the cancer cell that direct that cancer cell to grow and spread. Sometimes those genes are lazy and they're not directing it to do much of anything. That's a cancer that is less threatening. Sometimes those genes in the cancer cells are directing that cell to grow and spread fast, and that's a threatening cancer. These are things that I feel in my practice in 2021 are much more important to understand so that I can take the best care of the patient. I was telling you a moment ago how in the 70s, it was 75% survival. In the 80s, it was 85, and now it's above 90. Part of how we got that way, improving in that way, was understanding how the genes work in the cancer cells, knowing which cancers are lazy and slow, and we have one strategy for taking care of those. Which cancers are aggressive and fast, we have another strategy for taking care of those kinds of cancers. And it really opened our eyes, the doctor's eyes, to understand that now in the 21st century, we can understand how those cancer cells are working, tailor our treatments to the way the cancer cells are working, and get better success for women with breast cancer. So this is a kind of a long way of saying, I don't care so much about stage anymore. And I would feel very regretful if anybody left this meeting thinking, oh, I had a higher stage, so I must be worse off. That's not how we think about it in 2021. We think about it in terms of, what are those genes in the cancer cells doing to either make that cancer grow or not? And how do we address that to get the most success for our patients?
I think the point that Dr. Northfeld is making, just to add to that, is that we're really in an era of precision medicine, or personalized medicine, where we're really trying to tailor therapies based on the individual. And in some situations, we are able to use the genetic or genomic information about the tumor. But there's a mix of factors that really kind of go into our thinking about tailoring the surgery, the radiation therapy, the chemotherapy, or the hormone blocker therapy. So it still is really important for you to understand, as he said, kind of the physical extent of your tumor, but also the biology, and to keep asking those questions, because until you understand, because that's going to have a direct bearing on what therapy you get. And so you really want to understand the rationale of why we as physicians are recommending a certain treatment for you.
Thank you, Dr. Halyard. I'd like to go back to our survivors with a couple more questions. What was the most critical aspect of your breast cancer journey?
So for me, oh, you got it, Miss Sandy?
No, I'm listening to you.
So for me, it was my walk. So when I tell anybody, first of all, everybody is a survivor of something. We're talking about breast cancer today, but everybody is. And so for me, it was literally my walk. That was then and is now important to me. So I'm a woman of faith, great faith. And for me, it was BBC before breast cancer, and then ABC after breast cancer. That's how I see it. And what I did was I kind of evaluated my life before and then after. And that's what was most critical to me, because I'm thinking, okay, Pam, were you really living your best life? You know, this is not a stage play. This is the real thing. You know, there's no do-overs in real life. And so what breast cancer did allow me, chemotherapy did allow me, radiation did allow me, was a fresh new start. That's how I saw it. I was diagnosed at 42, and I thought, who at 42 gets to start all over again? So I felt as if I got the chance to start all over again. And even though I thought before that breast cancer, I just thought I was doing just great and, everything's fine. And it was, but I wouldn't want it for anybody, but I wouldn't take it away from my life experience, because it has made, I loved getting roses even before I was diagnosed with breast cancer, but I could just smell them even more now, because I just appreciate everything about life even more so. Because if we know nothing, we know there are no guarantees in this life. So for me, it was my walk. Not just who I am to myself, but who I am to others. Do I give? Do I care? Am I really that person I wanted to be? So just for the record, if you see me doing something wrong, I'm on my way to perfection. I'm just not there yet.
Oh, how beautiful, how heartwarming, how so special. Thank you.
So, Denise, I,
Yes.
I can tell you that Pam really made me remember my first journey. What was critical for me, believe it or not, was actually Dr. Halyard. She kind of saved me and helped me and walked me through, because I was going through so many different things in my life with my job, where I had took a leave from my job because I was so stressed out and went to the mountains in Greer to live for a while. But I went to Greer because things were just kind of complicated with relationships, with my job. Everything was kind of like going crazy. And then when I got to the mountains, I called myself going to get healthier and clear my mind. I was diagnosed with this DCIS, breast cancer, but it was pre-cancer, but still, I had to have surgery and do something about it. But Dr. Halyard called me while I was there and told me, and I didn't want to do anything about it. I was thinking, since it's just pre-cancer, can't we just let it sit? But she did walk me through things and just kind of like hold my hand while I was in the mountains. And then, I kid you not, it was years after, I kind of reflected on everything that happened. I believe, my faith, because I'm a woman of faith also, and leaving my job temporarily was a big step. But I thank God, I honestly do, where I was in the mountains in fresh air with no TV, no quiet. I mean, a lot of quiet where I can just pray and concentrate on me and get my act together. And then when I was treating at Mayo, I had the best caregivers, and I reevaluated my whole life and outlook on things. And I would ask. I remember Sean was my radiologist. I would always have nice conversations with him and other people that made me appreciate life more. You know, just I had time just to sit back and talk to other people and reevaluate. And it was critical just having faith, having friends, and just knowing I was going to be okay. I had some good people. I had good people.
Wonderful, wonderful. Thank you, Sandy. I know for me, in my journey, you talked about stress, and I was so stressed. I was so overloaded before I got my diagnosis. And once I got it, of course, I was scared. I was really scared. I have my oldest brother died of colon cancer. So the first thing that comes to my mind is, oh my goodness, I'm going to die. But as I was going through my treatments, I realized that there was an element of me not taking care of myself. And I was taking care of everybody else around me. And then I came down with something that was so debilitating to me physically going through treatments and mentally going through the treatments and where I was. That commercial, that little button that you used I forget whose commercial, but it was a red button that you would push, right? So it was like, stop. My life stopped. It seemed as though my life was just on hold until I got through. And so it is that journey of going through the initial getting well. I'm cancer free. And I remember ringing the bell on February 14th, um, 2017. And that's a really easy date to remember because it's Valentine's Day. Um, but or I should say, although there's another journey that started after that. So after the of getting cured, and it still is for me about staying well, staying whole, because the memory um, and I don't know if the memory's in the cells or just in my head, but but the trauma of that of feeling that I'm going to lose my life was really something. But again, as Pam said, also it's like I have a new life. I have a new start in life, and coming to Phoenix was part of that new start. And being here in Phoenix, I am very, very thankful that I am able to get the care from Mayo Clinic. Um, Dr. Northfeld and Dr. Helyard, can you talk a little bit about how that impact of stress? We know stress impacts a lot of our health. Anything specifically that you could add as it relates to breast cancer?
I have a comment about that. There's a very well-respected professor at Harvard Medical School in the School of Public Health, and I'm going to apologize because I'm blanking on his name right now, but he's an African-American man who's spent his entire career studying disparities in health, comparing white people with African Americans with Latinos and so forth. And his ultimate conclusion of all of his research is that stress is what creates much of the disparity. I'll give you an example. He looked at white men who have heart attacks and African American men who have heart attacks, same age, same income level, same insurance. And the African American men have worse outcomes after their heart attacks than the white men. And his conclusion from looking at that kind of information is that there's an emotional load, an emotional stress that racism places on African Americans that depresses the quality of their survival, the quality of their experience of health. That racism is a disease that pushes down the health of African American people in our country. Why would that matter in the context of breast cancer? Well, inflammation in our bodies can promote cancer, and we know that inflammation itself is promoted by stress, physical and emotional stress. So when people have looked at this kind of information, they've drawn a clear connection between the kinds of physical and emotional stress that African American people face in our country and their health outcomes because of the connection to higher blood pressure and inflammation and making it harder for kidneys to work, making it harder for the cardiovascular system to work, and so forth. So when you ask me, Denise, how does stress play into breast cancer outcomes, I look at that difference in outcomes between white people in America and African Americans in America, and I see the play of stress creating that difference. So one of the things that we absolutely have to do is eliminate the stress that exists within our healthcare system for African Americans so that we are seen as a place of comfort and a place of solace and a place of love and caring, and not a place anymore where abuses happen or where less equitable care is being delivered, because we need to at least overcome that kind of stress that we have control over within our environments in our healthcare system to provide better care for our African American neighbors. So, I'm grateful that I'm working at Mayo. I'm grateful that I'm in connection with the CBBC to work on these problems.
And I'll just add that part of the reason why the Coalition of Blacks Against Breast Cancer, CBBC, was founded was to provide that safe space. Because particularly living in the Phoenix metropolitan area, we don't always see other Black faces. And certainly we don't necessarily know who's had breast cancer, because sometimes we, as a group, don't talk about our illnesses, don't talk about cancer, we may say the C word or not say it at all, right? So CBBC was really formed to provide a safe space for people to come and to really let down that stress. And so some people think of a support group as a depressed place. Everybody's talking about their illness, et cetera. We have a lot of fun at CBBC. And I think Sandy and Pam can attest to that, and Denise as well, and Don. So we really do invite you, if you have a breast cancer diagnosis or know somebody, to please have them come join us. And now that we have a component virtual of CBBC, you can join from all across the country. We have people as far away as Florida and Indiana and Alabama and California, and everywhere. So there was one good thing about COVID. It forced us to go into a virtual world, which I think has really expanded our reach. But I do want to take an opportunity, if I might, Denise, to answer some of the questions that are in the chat. And would that be okay? So
Absolutely.
as we talk about, kind of what to expect with mammography, one of the attendees put in the chat that she'd had additional diagnostic imaging for one of her breasts that was scary and can be stressful, obviously. And it turned out to be nothing of concern, but she does have dense breast, and she's concerned that this will be an ongoing issue going forward. And it really points up an important point that as you're having a mammogram, particularly a screening mammogram, or even a diagnostic mammogram where they're checking out something that might be wrong, making sure that the place that does your mammogram has your prior films. And going forward, they have access to those prior films, either at the same location or those films go to the next location where you're having your mammogram, because a lot of what kind of helps the radiologist know if something is abnormal or not is by comparing prior films to current films. So it may not need to be for the person that is answering or ask the question in the chat that she's always going to have multiple films. They may have gotten enough information to know that going forward, she may not have to have other things. But I know it's stressful and scary, but do know that the radiologists really want to be thorough. And so when they recommend other more images on mammography or perhaps an ultrasound or an MRI, it's really trying to look to answer those questions about whether this is something that needs to be followed up on or not. Don, there's a question for you about can lower doses of AI be taken if experiencing a lot of side effects?
Sure. So aromatase inhibitor is a type of drug that we use to prevent breast cancer from coming back. Sometimes we use it to treat breast cancer that is, present in bones or in lungs or liver, but primarily aromatase inhibitors are used to prevent breast cancer from coming back after a person has had surgery and radiation and so forth. Those drugs can have rough side effects. They can cause hot flashes, joint stiffness, vaginal dryness, a whole variety of things that can be unpleasant. When that happens, at least in my practice, it's my obligation to figure out a way to help a woman overcome those problems. And there are a variety of ways to do that. If I've got a woman on one aromatase inhibitor and she's not tolerating it well, I'll have her try a different one, because there are several of these medicines available. So if one doesn't suit her because it's causing a problem, let's have her try another one. And very often, just by switching to a different medicine, the problem goes away and the person can continue and get the benefit to prevent a relapse of her cancer. But sometimes even after trying all of them, that it's not going to work. They're all going to cause side effects. Well, we also have tamoxifen, which is an older drug that's available. Sometimes when a woman can't tolerate an aromatase inhibitor, she can tolerate tamoxifen and get the benefit that way. Another question that I might ask at a certain point is, well, if you can't tolerate any of these medicines, let's reevaluate what we're doing with them, because maybe you don't need it after all. I might see a woman and tell her that we can reduce her risk for relapse from 8% to 6% by taking this medicine. And, that sounds good to the woman at the time. I mean, any reduction in relapse risk sounds appealing, right? So she tries the medicine, but she doesn't like it. It makes her sick in some way. Well, then I should get her back in the office and say, okay, remember, we're only reducing your relapse risk from 8% to 6%. Maybe that's a trivial enough benefit that it's really not worth pursuing if the medicine's going to make you ill. So we have to have conversations like that about what are we really trying to accomplish. Sometimes we better work harder and try to find a better way to take care of the person. Sometimes taking them off the medicine and telling them, your life is going to be great regardless, could be a good answer.
Thank you so very much. There's another question, and it is, how are the outcomes for other minority communities like Latinx and Indigenous communities?
Yeah, the breast cancer outcomes for Native American women are poor. They have less success. Native American women have less success in getting their breast cancer treated than African American or white women. And that has, again, a lot to do with access to care. Ability to obtain a mammogram and to see a doctor can be very challenging for Native American women living in strained circumstances on reservations and so forth. There's also, racism that's creating stress for those folks, that's contributing to a worse outcome with their breast cancer. When it comes to Latino women, their outcomes are roughly similar to what happens to white women. One thing I have to say is that, the age range of Latinas skews younger. The growth of the youth segment in the Latina population is huge compared to population growth amongst African Americans and whites. And so that means that there's less breast cancer in the Latina community because, breast cancer the risk for breast cancer tends to increase as we get older. So it'll be interesting to see as this youth wave in the Latina population moves later in this century into an older age group, whether the problems with breast cancer increase in that group. What we have to do right now is make sure that as many Latina women as possible get their mammograms, because if we can prevent a wave of breast cancer from coming into that population by being on top of their screening, we're going to do them the biggest favor possible. I don't know if that fully answers the question, but that I'll stop here.
Thank you. One last question. For an African American woman with a family history of cancer on both sides of her family, including breast cancer, how often should a breast cancer screening be done?
So that's a really good question. And the first thing that I'll say is, please keep in mind that the vast majority of breast cancers are not linked to family history. Only about 5 to 10% of breast cancers really have a genetic link that we know of today. That's such as BRCA1 and BRCA2 genes and some other genes that cause you to have breast cancer. That may change as we get more information in the future, but that's what we know today. So why do I say that? It's because many women say, I didn't get my mammogram, I didn't do my breast exam. Nobody in my family has breast cancer, so I didn't think I was at risk. Well, the vast majority of breast cancer patients don't have a family history. So it is important for you actually to know what your family history is of cancers and when and who got it and at what age, because not all cancers really make us as healthcare professionals think that there is a familial or genetic link. So I can't really answer that question generally, but I will say that if you have a question regarding your family history, and particularly if there's breast cancer in a first degree relative, like a mother or a sister or a grandmother, multiple relatives, young age of onset, associated colon or prostate cancer, you might think about seeing a genetic counselor. They will do what's called a pedigree. They will ask you your family history. And then they will give you kind of a rough estimate as to whether they should do genetic testing to determine if you have a gene that puts you at higher risk, which can then translate into how frequently you get your breast screening done, or at least what stage, or excuse me, what age. For me personally, I had a mother that had breast cancer at 43, had multiple other family members with breast cancer. I finally got my genetic testing done, and I did not have a family history of a gene that was identifiable. Shocked me because I was sure it was there, but it wasn't. So we can't always tell from our family history. Dr. Northfield, do you have any other additional words regarding this question?
Yeah, I think part of the question I heard was, okay, I've got this family history of cancer, which seems pretty extensive. How often should I be getting mammograms? Well, the answer to that is to get genetic testing done. If you have a genetic predisposition to cancer, then we're going to recommend mammograms every 6 months. In other words, not once a year anymore, but every 6 months. And furthermore, we'll not just stop at mammograms, we'll probably alternate mammograms with MR scans or some other technique every 6 months. So a woman who has an identified genetic predisposition to cancer needs to be screened more frequently, because then we're going to catch the cancer early and be able to help her more effectively. So my answer to that question, I agree with everything Dr. Halyard said, but specifically, how often should the screening happen? Well, that's determined by whether you have a genetic predisposition or not. So get your genetic testing done. If you have a genetic predisposition, then we're going to want you to be screened every 6 months.
And please know your family history. I can't stress that enough. Often we don't know our family histories, and there can be some surprises in there that could actually impact your health.
Thank you, doctors. This last question I'd like to direct first to our survivors. What words of wisdom would you like to pass along to those newly diagnosed with breast cancer, and also those who may not have been diagnosed and are here to learn?
Well, it's Sandy again. I am just saying exactly what Dr. Halyard said. I think we just need, and I'm a retired nurse too, and we need to know our family history. That's a good thing. But we also need to know our own bodies. We need to pay attention to our bodies. We need to take control of our health instead of being reactive to something. We need to be proactive. We need to, do our self checks. We need to do our mammograms. We need to get second opinions because we have had um, one member in particular that was a young African American woman in CBBC that had found something, a lump in her chest or something. She had it checked out. The doctor said it wasn't anything, but she knew that it was something. And she went and got a second opinion. If you know your body, and you don't always have to fall back on the professional. If you know your body and you know it's not right, seek seek another opinion. Find out what's going on with you. Look for treatment options when you find out. I know I'm giving you a whole lot of information, but know your body, know your family history, uh, get another opinion if you don't like the opinion that you get, know what treatment options you have available to you, but also have somebody that can help you navigate. If it's totally unknown waters to you, I can tell you that CBBC, for me, that support group helped me tremendously, not only because most of the members looked like me, but there were also medical professionals that don't look like me, like Dr. Norfelt, that shared information with me. So many other doctors there. And it's not just open to Black people, it's all kind of people there. So it was all inclusive, but the focus was on, minorities, African Americans and stuff. So it made me feel good to have other people there with me navigating and helping me. So have faith. If you have good people around you and you have positive people around you, you're going to have a good outcome. You might have to get rid of some of those negative people saying negative stuff and crying and whining. So
Right.
get you a good circle.
Thank you, Sandy. Absolutely. Very good advice. And Pam?
So words of wisdom. I'm going to piggyback off of what Miss Sandy, some things she said. Number one, it's funny because you say get a second opinion, but if we were shopping online for shoes, for example, and we didn't like the price on one, we would check a number of sites. Or if we didn't have the right color, oh my gosh, we're not buying. We would look and look and look until we found the shoes to match the dress, to match the purse, however that goes. So I'm saying that it's worth you take that time for yourself and others, because we as women, all women, tend to be caregivers. So you take that time to do things like that. It's worth it for your health. I remember thinking, oh, well, I'll be fine. But what I found out really about my diagnosis was that there are people in this world, it may be true or maybe not, but who can't get along without you. It might not be for you. It could be for your daughter, your sister, or whatever. So and then there's a couple things I want to say about access and options. I said access earlier because Dr. Northfelt did mention that, having access, but then having options. So the earlier we are diagnosed, the more options we have. And then you get to meet people like Dr. Halyard, in my case, Dr. Jurescu. She's not on the line, but she was one of my caregivers, someone who helped me through this process. Dr. Northfelt, Dr. Halyard, Dr. Gornett. I mean, all these people get to be in your circle, like Miss Sandy was saying. So that's all I'm going to say, but do take care of yourselves. If not for yourself, for the people who love you.
Absolutely. And I know our time is about out, but I would really like to say, in terms of my words of wisdom, stay the course with your treatment. I know I was far along in my treatments, had maybe 3 more chemotherapy treatments to go, and I didn't want to go. It was just so overwhelming. And I did have the encouragement to, you've gone this far, keep going. And I'm glad I was given that encouragement. The other thing I would like to also say, encourage is conversations, the conversations with our family and friends and loved ones. Because as Dr. Halyard mentioned, we don't like to talk about it, but we have to open up conversations and share what's going on with us health-wise. And lastly, get involved in clinical research so that we, African Americans, can be part of the medical solutions that will help save our lives. Dr. Halyard, Dr. Northfeld, any other closing words before I thank everybody?
Don't forget about CBBC. If you're diagnosed with breast cancer, or you know somebody that's diagnosed, or you just want to be a supporter, we're open to all, as Pam said. And you don't have to be a Mayo patient. I don't want, just because everybody here on the panel has a Mayo connection, I'd say more than half, if not 3/4 of the folks that are involved with CBBC are not Mayo patients. So it's open to all, and we look forward to welcoming you.
And I'll just add to that, every third Sunday of the month, we meet our survivor group. And of course, supporters, we welcome you to share and visit us on info@cbbcaz.org. And Dr. Northfeld, any closing remarks?
I just want to say again how grateful I am to be on the same screen with all of you very, very impressive people. I'm deeply, deeply grateful.
Well, I want to thank our audience for joining. We do hope that you have gotten information that is valuable to you. Thank you, all of the panelists, for making this a really awesome hour. Thank you again. Bye now.
Thank you.
Thank
Bye-bye.
you. Bye.